that are on the market. We are happy that we had, I think, some industry sponsorship for this meeting here, but as it's not an industry course, which allows us to openly discuss potential strengths and weaknesses also of one or the other device. And to do so, I will first start now with the self-expandable devices. Guy is going to touch on self-expandables, so Sapien and Lotus. And then later on, maybe after the coffee break, we will see, I will give you a talk about how to choose, at least in my perspective, the most optimal device based on the individual patient anatomy. Of course, you could also discuss in general whether or not it does make sense to have different valves on the shelf depending on the volume of your program. So, for instance, we currently in Berlin do around 600 transcatheter valves a year. So we have basically all the valves that are available, but this doesn't make sense if you do only 50 valves a year. Then it does make sense to concentrate on one device and maximum have two different versions available. So the most, let me have a look, which one is it? The most common used versions definitely are the Medtronic Evolut family and the Edwards Sapien. So I've decided to touch a little bit on both, I would call them core valve-like devices, which are the Evolut, the newer generation of the core valve, and the Abbott Portico, because they share a lot of similarity at first glance, but on second glance they behave a little bit differently. So if you see them on X-ray, you'll think, okay, this is basically the same device manufactured by two different companies. And yes, they share a lot of similarities, but if you have a closer look, they behave very differently. So what they all share and in common are that the idea of how these devices are deployed is that you simply retract the capsular that will release a self-expandable 19-hole stent. And then around up to 80%, which gives you the option to assess initial, and this is important to understand, initial valve function, and then might also allow you to resheath and go for a second attempt. But we are aware some things might happen with that 20% final release that are hard to anticipate beforehand. So this is how the delivery system looks like. Now the newer version of the Evolut, the R version, has that integrated inline sheath, and this brings you down to this OD of 18 French. So clearly this is the lowest profile device that's currently available on the market. Porticos currently still requires a 19 French sheath. 19 French sheath means add 3 to get to the true OD, which means 22 French hole that you will have to make in the vessel. Also, you also can use the Portico in the sheathless fashion. Also, this is not an off-label. So both devices in the first stage need to be anchored into the calcified annulus, and you can already see some of these technical problems that you sometimes face. It's all about the alignment of the device with the aortic annulus. So you will not go to the typical 3 nadir view as you would use for the self-expandable Edwards, but you will need to adjust your C angulation so to have these radiopaque markers not in a circle but in a straight line. So you opt to choose perpendicularity onto the delivery system rather than on the annulus. And why is that? Because in most of the cases you will not have perpendicular alignment to the annulus, so usually you have the tendency to end up too high on the non and too low on the left, and this is why for both systems it's important to concentrate on this part of the valve only and try to get it as high as possible on the non-coronary side, and then once if you fully let go of the device, it will snap into position and somehow self-align itself within these two extremes. So a tiny difference is that the Portico is not occlusive at any time of the procedure, whereas the Evolut has a very brief episode where it is completely occlusive. And this is important if you have a high pressure or have a good ventricle, then you tend to get ejected with the Evolut. And this is why most centers use a brief episode or not rapid, but rather fast pacing around 140 or 150 beats per minute. Whereas with the Portico, this is not required because it's not occlusive at any point of the procedure. So if you are up to that 80% delivery, you still have the option to resheath and to go for a second approach. This, of course, giving you a lot of peace of mind, especially in a little bit more challenging root pathologies. But also it has a downside because it's not really possible to assess the final valve function at these 80%. This can only be done with the direct flow, which is off the market, and with the Lotus system. These are the only versions that really allows you to fully assess the final valve position and then resheath or reposition. But still, it's a good thing, and I think this has improved the results, especially for the core valve, tremendously, because people are now a little bit more brave to aim a little bit higher, because if you get ejected, not a bad thing, you can resheath and go for a second attempt, whereas with the old version, you need to drag the whole thing through the arch and then into the caps, into the sheath again, and this is why most core valves ended borderline low, which then created leak and pacemaker. So this is what I was talking about. So you can see once these devices snap completely open, they will make a kind of adjustment move, so to then get a balanced position in between the typically borderline low position on the left and typically borderline high position of the none. So post-ballooning is a frequent issue with all self-expandable devices. It depends, of course, on the landing zone, but also on the radial forces that these devices have. We typically don't pre-balloon any longer. We rather do post and pre-ballooning, and you can expect around 30% of pre-balloonings in the usual patient cohorts. So with both devices, if you chose them wisely based on the individual anatomy, you can get perfect results. And then there's a slight difference if you consider it down the road, because the cells of the core valve are a little bit more narrow, so it might, the portico might offer an advantage in later PCI procedures down the road. One other difference here is, you can nicely see that here, the Evolut has a supraannular valve design, typically gives you perfect gradient, also in the setting of valve in small degenerated surgical bioprosthesis, whereas the portico has rather an intraannular valve seating similar to Lotus or Sapien, so you cannot expect perfect gradients in super small anatomies. So this is again a closer look on the portico device. It's always important with these things to see at which level the first crossing of the cells is, because this is used for orientation. Also, you need to be aware on how high this covering goes in regard to where the sweet spot of these valves ends. Of course, with both devices, there are a couple of trials available. I don't want to go into detail with this one. The latest advance here from Medtronic is that they released the Evolut Pro just a couple of months ago. So what has changed in comparison to the Evolut Pro, to the Evolut R? It's basically that they kept this stent design, so it's the same stent than with the Evolut R. Also, the delivery system is more or less the same, but what they added is this external wrap here. I think also because of patent issue, they could not use a kind of a covering as they have it with Lotus or with Sapien, but they used a pericardial wrapping, which is meant to again increase the coaptation zone and is meant to further reduce the rate of PVL. So there's not much data around here. It's only 60 patients that have been published, and based on these cohort, of course, it looks like a very good, effective method. But again, we have to wait until the more realistic real-world data will become available. I also use it since a couple of weeks, and my personal impression is that yes, it does help a little bit, but there's one downside with it, because now it's not 18 French OD, but now it's 20 French OD. And whenever a company is willing to invest some French sizes to get more performance of the valve, I think this is something that we all should welcome, because it really doesn't matter whether or not you have 18 or 20 French. It's more about perfect valve function in the end. And this is again how the engineer thought that this thing is going to work, by adding this blue layer, the pericardial layer, that they increase the coaptation or the surface contact with the calcified structures in the annulus. So in the end, the delivery system is exactly the same, as mentioned, 2 French larger diameter. Of course, the valve performance is also the same because it's basically the same stent. You could argue it's almost an academical discussion whether or not you should use the Pro for the valve-in-valve, or whether or not in those settings it might even be a negative thing to have an additional wrapping. And also be aware that the 34 millimeter version of the core valve, so the current Evolut R, is not available as a Pro yet, and also has a different shape of the stent with more flaring in the LVOT, which tends to dive a little bit faster in the LVOT. So it's a slightly different deployment mechanism compared to the other sizes. So this is just basically for the quite commonly used Evolut and Portico, which came later to the market. And then there's another self-expandable platform, which is from, used to be Symetis as an own company, was then acquired by Boston. So now Boston has two TAVI systems, the Lotus, which is currently on hold, most likely is going to come back early next year. And the other version is now the Symetis Accurate family. They have it in two versions, transapically and transfamily. And just briefly want to familiarize you with this one because it has some market share, at least in Germany, and I expect also that now with the sales power of Boston will be more oftenly seen in the rest of Europe. So this is how the valve looks like. It is a self-expandable stent and has these kind of weird-looking crown, which is meant to engage the calcification. And then you have these so-called stabilization arches, and they are there to prevent tilting of the valve during the deployment. And then you can see that the valve has an extreme supraannular position, so usually you will get zero gradient with such a configuration, but also you need to be aware of the design, because it's obvious that the commissure posts here are not covered, not fenced. So there's no cage around those, so you should not overdo it with post-dilatation, otherwise you could rupture the commissures here. So the landing zone, or the sweet spot, is around a 7 millimeter pericardial skirt, and also this version is going to become available early next year as an active seal version, where they add a kind of an adaptive seal around these stent edge here to improve PVL. So all the companies are following more or less the same route to get better results in regard to PVL. It is available in 3 different sizes, not labeled by numbers, but by small, medium, and large. And we lack the XL version, which is under development, so we can only treat patients with an annulus up to 27. So this is how the delivery system looks like. This is the transfemoral version, quite flexible catheter. It travels through a more or less 18 French sheaths, and it also is distributed with a special sheath, which is called the Transglide, which is also a very smart concept. You first deploy a kind of a hydrophilic sock into the vessel to reduce friction, and only then you advance the sheath needed for valve deployment. And so it's another technical way on how to avoid friction on the vessel wall. And the updated low-profile version for the transapical delivery is now more or less equivalent to the Sapien system, so it's also OD of around 20 French, which is more or less same as an 18 French sheath. So the transfemoral delivery has 2 different knobs, one for step 1, one for step 2. The in between is a safety button, and what is different to all the other self-expandable devices is that it is not deployed, it's more top-down deployment, so it's the other way around. So the first step, you will release the stabilization arches as well as the upper crown. So with the transfemoral version, because if you retract the capsule this way, you first will see opening of the upper crown and then the stabilization arches. And these arches are actually a nice feature, because what it does is it will uprighten your prosthesis within the annulus, and all these issues that you sometimes have, a suboptimal angle of approach with either Evolut or Portico, can be overcome by that. The downside is that you cannot resheath. So you start to understand that there are lots of pros and cons with all the different devices, and it really takes a while until you understand all these different features. So once you have it in good position, then again, a benefit of this valve is, if you have a close look during the deployment here, it's absolutely stable. So once you manage the initial positioning, the arches are going to help you to uprighten the prosthesis, then it's going to be a super stable deployment, even without rapid pacing. The rest of the procedure is pretty much the same. You need to make sure that the delivery system is not entangled. This can happen with any self-expandable devices. And then, of course, valve function assessment, potential post-ballooning in around 30% to be expected. Again, supraannular valve positioning, quite extreme actually, which means there will be never ever a residual gradient, and data is confirming that. Just want to go fast forward here to the transapical version. I know, this is why we skipped the last presentation, because it is too much to cover. And if you don't see these devices, I think this is very important. We cannot discuss later on which device to choose for which patients.
To combine the two lectures, to continue with which one for which patient.
Yeah, but first we need to show you these Sapien features and the Lotus, because we have so many devices on the shelf these days. That's okay. So just very briefly, the transapical version. It also has a low-profile delivery system, and what very neat feature, and we can have a philosophical discussion about that later on, is that it's the only device left on the market that allows you to go for anatomical rotation. So you see this tiny radio marker here and the longer one, and if you orient it in a way that this one is matching the guide wire and the shorter one is on the left on the screen, then if you implant in a typical Srinadia view, you can be sure that you will deliver the transcatheter prosthesis with commissures to native commissures, and it's the only device that allows for that. Whether or not this is beneficial, again, is a more philosophical discussion. With that, I hand over to Guy to cover the last remaining commercially approved devices, which is the Sapien and the Lotus, which is currently on hold.